Bismillahirrahmanirrahim. This is Dr. Anamishay, Assistant Professor of United Medical and Dental College for Karachi. So today's topic of my lecture is hodgkin lymphoma, and these are the objectives which will be covered by the lecture. Nodular sclerosis, cellularity, lymphocyte lymphocyte depletion, lymphocyte. These are the basic classification of Hodgkin lymphoma that contain the external cells and variants. We will discuss its variants and pathogenesis, morphology, and mitigations. What is Hodgkin lymphoma? It is basically a group of lymphoid neoplasm. It arises in a single node or chain of nodes. It spreads first to anatomically contagious lymph tissue and characterized by the presence of neoplastic giant cells called reed Sternberg cells. The factors from reed Sternberg cells induce accumulation of reactive lymphocytes, macrophages, and granulocytes, which make greater than 90% of the tumor cellularity. And the hematogenous spread occurs to liver and multiple sites. It is the most common cancers of young adults and adolescents, but also occur in the aged people. These are the risk factors of Hodgkin lymphoma. Like there are no clear risk factors, and several indicated are Fc virus, immunodeficiency virus, woodworking like carpenters, rare familial aggregation, socioeconomic status, and prolonged use of growth hormone. In the pathogenesis of Hodgkin lymphoma, the Reed Sternberg cells undergo recombination and somatic hypermutation. And these cells derive from a germinal center or post-germinal center of B cells. These cells are the classical hallmark of failure to express most B cell specific genes, including the immunoglobulin gene due to widespread epigenetic changes of uncertain etiology, and the activation of the transcription factor NFKB is common event in classical Hodgkin lymphoma. This is the picture showing the pathogenesis of Hodgkin lymphoma, like how how the changes occur in the germinal center or due to extravir virus cell converted to redistributed cells and eventually develop the Hodgkin lymphoma. These are the vectors that influences the pathogenesis, like cytokines such as interleukin 5, interleukin 10, interleukin 13, and transforming growth factor beta and chemokines. That includes DARC, MDC, IP10, and CCL28 are secreted by the external cells, after which they lead to fluid accumulation of reactive cells and tissues involved in classical and these reactive cells produce vectors that promote the growth and survival of the tumor cells and further modify the reactive cell responses. These are the clinical features, like it is asymptomatic lymph node enlargement in 80% of cases. The mediastinal lymph node involvement goes chest pain, cough, and dyspnea in 50% of Hodgkin lymphoma cases. There is infradiaphragmatic involvement in 5% cases, pruritus, alcohol-induced pain in involved lymphoma. Patient may develop nephrotic syndrome, erythema nodosa, cerebellar degeneration, immune hemolytic anemia, thrombocytopenia, hypercalcemia, fever, weight loss, and night sweats. These are the gross picture clinical appearance in Hodgkin lymphoma cases, like the picture shows in neck enlargement and the mass in the neck. This is the gross picture after surgery of the lymphoid tissue or the tissue the mass containing Hodgkin lymphoma. This is the morphological picture of breed Sternberg cells, which is the hallmark of breed and Hodgkin lymphoma. These are the basically large cells greater than 45 micrometer in diameter. These are binucleated and bilobed centrally placed nucleus. The large central nucleus is surrounded by clear halo-like eye appearance shown in the picture. The variants of pre-Starbuck cells are mononuclear cells, omphoid cells, lacunar cells, and lymphohistiocytes. And when we talk about the immunohistochemistry marker, the CD15, CD25, CD30, CD45, EMA, S100 cytokeratin shows a positive staining of eyes. These are the morphological patterns of pre-Starbuck cells. The picture A shows the typical RS cells, other one is mononuclear variant like the cells show single nucleus. The third one is lacunar variant like there are lacunes in this tissue and these are the lymphocytes, I think. WHO classifies Hodgkin lymphoma in five different subtypes, includes nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depletion, and lymphocyte malignancies. When we talk about nodular sclerosis, the morphology in the picture showing that there are frequent lacunar cells and occasional diagnostic pre-Sternberg cells. And the picture is also showing background infiltrate composed of T lymphocytes, eosinophils, macrophages, and plasmacytes. There are fibrous bands dividing cellular areas into nodules like this. This is the fibrous band. The cases of nodular sclerosis shows positive staining of ISC in CD15, CD30, and usually EBV associated. The typical clinical features are it is the most common subtype, usually stage 1 disease appearance. Okay. The frequent mediastinal involvement, equal occurrence in males and females, and mostly occur in young patients or young adults. The mixed cellularity type includes the morphological picture shows the frequent mononuclear and diagnostically Sternberg cells, and the background infiltrate rich in T lymphocytes, eosinophils, macrophages, and plasma cells. On IHC, this shows CD15, CD30, and 70% EBV positive cells. And the clinical features include that more than 50% present is stage 3 and stage 4 disease. Males are more predisposing than the female, and biphasic incidents like peaking young adults and again in adult older than 55 years. The lymphocyte rich variant on morphology, it contains frequent mononuclear and diagnostic T responder cells, background infiltrate rich and T lymphocytes. On ISC, they express CD15, CD30 in 40% of EB positive cases. Clinically, they mainly present in males and females tend to be seen in older adults. Lymphocyte depletion variant shows it is a very reticular variant and contain frequent diagnostic pre-Sternberg cells and variants that shows paucity of background reactive cells. IHC, they express CD15, CD30, mostly EBV positive patients. Clinical features like it is uncommon type, occurs in older males, common in HIV-infected individuals, and present with advanced disease. The other variant is lymphocyte predominance, and morphologically they appear as there were background follicular dendritic cells and reactive B cells and tissue covenant cells may also cause histiocytes. On IHC, they express CD20, CD15, and CD30, and clinically they are uncommon type, occurs in young males, involve cervical or axillary lymph nodes, and show mediastinal involvement. I hope it is it was a clear lecture delivered to you. Thank you.